Contents Introduction: How to use your learning guide. What you will learn. Structure of this resource: incontinence and its effects, urinary and fecal incontinence. Interventions, products and practices for incontinence. Common interventions. Lifestyle interventions for management and treatment of incontinence. The use, care, removal and disposal of continence products. Common collection aids, infection control practices. References: 22214141618192224. 14141618191618192224. 18192224. 192224. 2224. Introduction: This unit standard is designed for those who have experience of working as a healthcare assistant or support worker, or have just begun caring for people with continence needs and wish to gain a nationally recognized qualification. How to use your learning guide. This learning guide supports your learning and prepares you for the unit standard assessment. There are activities to do and scenarios to guide your learning. This guide relates to the following unit standards. 28546 Describe incontinence and interventions to assist a person in a health or well-being setting. Version 1, Level 3. 5 credits. This learning guide is yours to keep. Make it your own by writing notes that help you remember things or where you need to find more information. Follow the tips in the notes column. You may use highlighter pens to show important information and ideas. And think about how this information applies to your work. You might find it helpful to talk to your workmates or supervisor. Complete this learning guide before you start the assessment. What you will learn: when you have finished the learning for this unit standard, you will be able to describe common types of incontinence, observable indicators of incontinence, and factors that may affect a person's ability to remain continent for a person in a health or well-being setting. Interventions, products and practices that may assist people living with incontinence in health or well-being setting too. Structure of this resource. Hygiene is a very personal issue. From a very young age we are trained to control our urges to go to the toilet, so being incontinent can make it feel as if one is losing control. This can affect a person's sense of dignity and self-esteem. Many people find it very hard to accept that they need help from someone else in such an intimate area of their life, even or sometimes, especially if from someone very close to them. This resource has 3 main sections. 1. Types and indicators of incontinence and factors that affect continence. 2. Interventions, products and practices that may assist people living with incontinence. 3. Infection control practices. The content of this resource is intended to provide basic knowledge for understanding incontinence and interventions to assist a person with incontinence. Information and guidelines for applying this knowledge in practice can be found in other resources and from the New Zealand Continence Association website at http://www.continence.org.nz/incontinence and its effects, http://www.alzheimers.org.uk/site/scripts/documentsinfo.php. Document ID = 136. Incontinence is the term medical people use to describe the loss of control of the muscles the body uses to get rid of liquid and solid waste products, urine and feces. It's not a disease in itself but is often linked to other medical or physical conditions. Incontinence can severely impact on a person's quality of life. People can experience urinary or fecal incontinence or a combination of both. However, people can also experience problems with constipation, which can also cause problems. In this section you will learn about common types and causes of urinary incontinence, common types and causes of fecal incontinence, observable indicators of urinary and fecal incontinence, factors that may affect a person's ability to remain continent. 3. Urinary and fecal incontinence. Continence is a touchy subject. Andrea Lord, continence specialist, educator and advisor. Urinary incontinence. Urinary incontinence is defined by the International Urogynecological Association (IUGA) and International Continence 2009, as cited by the NZ Continence Association as the complaint of any involuntary leakage of urine. The Association for Continence Advice 1993, as cited by the NZ Continence Association, says, incontinence is not a disease, but is a symptom of an underlying disorder. The two main disorders for urinary incontinence are bladder storage dysfunction and bladder voiding dysfunction. Bladder storage dysfunction is where the bladder can't store urine properly. The dysfunction manifests itself through stress incontinence, the involuntary leakage of urine on effort, exertion, coughing or sneezing. This can be the result of weakness, inefficiencies in the urethral sphincter, and may be caused by childbirth, traumatic obstetric delivery, hysterectomy, prostate surgery, chronic constipation and straining over active bladder (OAB) syndrome. This may present itself by a person feeling the need to pass urine even though the bladder may not be full. Nocturnal enuresis or bedwetting. Frequent urination, more than 6 to 8 times during the day. Nocturia, going more than 2 times during the night. OAB syndrome is also known as urgency incontinence or urge incontinence. It may be caused by nerve damage, surgery, neurological conditions or diseases, for example, multiple sclerosis, Parkinson's disease, stroke, spinal cord lesions. 4. Aging, a lack of estrogen, side effects of drugs, urinary tract infections, UTI, causing pain or discomfort when passing urine, bladder stones and tumors. Mixed urinary incontinence is a combination of stress incontinence, wetting oneself by sneezing, coughing and exercising, and an overactive bladder (OAB). Bladder voiding dysfunction. Bladder emptying, voiding dysfunction is where the bladder can't empty itself effectively. This may be due to the bladder not contracting effectively to empty itself, an underactive bladder, the urethra not opening when the bladder is contacting, for example an outflow obstruction, or a combination of both. It may be caused by damage to the lower spinal cord or to the bladder's peripheral nerves, or neurological conditions like multiple sclerosis or Parkinson's disease, or trauma or surgery to the pelvic region. In men, the potential for bladder emptying, voiding dysfunction may occur when their prostate gland enlarges and constricts or obstructs the urethra. Common difficulties include trouble starting the flow, a slow stream once started, leaking after passing urine, feeling an urgent need to pass urine, post-void symptoms such as dribbling urine immediately after finishing passing urine. For men, this typically occurs after leaving the toilet. 5. Male bladder ureter peritoneal coat detrusor smooth muscle external urethral sphincter pelvic floor muscle prostate gland. Many people may not experience bladder storage dysfunction and bladder voiding dysfunction, but are still incontinent. This may be due to functional incontinence, defined by the Department of Health and Aging, Australia 2004, where problems getting to the toilet owing to environmental, physical or mental difficulties cause incontinence. For example, physical disabilities or handicaps may prevent a person getting to the toilet and/or removing their clothing. Medical problems that may contribute to functional incontinence include dementia, arthritis, Parkinson's disease and diabetes. Other conditions may cause a severe loss of physical and cognitive function, vision and communication and comprehension difficulties, and sometimes the inability to communicate in any way. Observable indicators of urinary incontinence include bladder voiding frequency or hesitancy or urgency or nocturia, poor urinary stream or flow or straining to pass urine, post-void residual urine -30%, bladder volume post-void dribbling, overflow incontinence and nocturnal enuresis, bedwetting, urinary tract infection, skin rash or reddening of the skin due to extended contact with urine, occasional loss of bladder control from mild, a few drops, to 16 moderate, wet underwear to severe, wet outerwear. Accidents when coughing, sneezing, laughing, bending, lifting and/or doing any physical activity that strains the bladder, sudden urges to use the toilet and an inability to get there in time, wet bed clothes, chair or sofa seat, wet continence products, anxiety about drinking fluids for fear of wetting oneself, fecal incontinence. 1-inch incontinence is not an illness, but a symptom of an underlying cause. Andrea Lord, continence specialist, educator and advisor. Fecal incontinence is defined by Norton, 1996, as the involuntary passage of feces and/or flatus passing wind at an inappropriate time and in an inappropriate place, and as any involuntary leakage, solid, liquid or gas, Norton 2004. Fecal incontinence may be experienced either passively or urgently. Passive incontinence includes the unconscious passing of a stool and/or no warning before the leakage occurs. The brain doesn't register the message that a person needs to go to the toilet. Urgency is when a person may suddenly have the sensation of a full rectum and feels a strong urge to go, and they may have to rush to the toilet to make it on time. Some causes can include pelvic floor damage or damage to the back passage, anal sphincter, resulting in weakened muscles. Diarrhea is defined as the frequent, more than 3 times per day, passage of unformed stools as per the Bristol Stool Form Scale Type 6 and, in the case of those with chronic diarrhea, occurrences for over 1 month. Norton and Chelvanayagam, 2004. Diarrhea can lead to fecal incontinence. Diarrhea may be either acute or chronic. Causes of acute diarrhea include infections such as viruses, norovirus or rotavirus, bacteria E. coli or Campylobacter or Salmonella parasites. The Giardia intestinalis parasite causes giardiasis, adverse drug reactions, overuse of laxatives and antacids, tumors, colitis. 7. Diabetes. Causes of chronic diarrhea include anxiety or emotional distress, excess alcohol and/or coffee, damage to the intestines, for example, caused by radiotherapy or a hernia, a food allergy, too much fiber, side effects to various medications, such as laxatives, antibiotics, statins or antacids, irritable bowel syndrome, IBS, ulcerative colitis and Crohn's disease. Constipation. Constipation is defined by the NZ Continence Association as lumpy, hard stools types 1 to 2 on the Bristol scale, and a sensation of incomplete evacuation which may occur a quarter of the time. It also includes passing 2 or fewer bowel motions in a week. Norton and Chelvanayagam, 2004. Bristol Stool Chart. Type 1, Type 2, Type 3, Type 4, Type 5, Type 6, Type 7. Separate hard lumps, like nuts, hard to pass, sausage-shaped but lumpy like a sausage but with cracks on its surface like a sausage or snake, smooth and soft blobs with clear-cut edges, passed easily, fluffy plesses with ragged edges, a mushy stool. Watery, no solid pieces. Entirely liquid. 8. Constipation may be caused by internal causes, such as a hormonal imbalance, medical problems, for example diabetes, a lack of mobility and/or exercise, neurological problems, for example stroke, prolapse, external factors such as inadequate fluid intake, inadequate fiber in the diet, the side effects of some medication, for example, antidepressants, pain relief, the external environment, attitudes of the person, staff, family, phono or support workers, psychiatric, psychological disorders. Impaction occurs when the bowel is overloaded with stools, solid or soft putty-like consistency, causing a blockage. Severe constipation can lead to fecal impaction and incontinence. People most at risk of impaction are those who are relatively immobile, most of their day is spent sitting or in bed, or who have diseases of the brain or nervous system that damage the nerves in the intestines, muscles, or who are on medication that slow the passage of stools through the bowel. Overflow occurs when the stool stuck in the rectum creates a blockage which allows only a watery discharge to pass around the blockage, leading to leaking. Overflow is most common in people with long-term constipation who may have taken laxatives for a while and the muscles of the intestine forgetting how to move stools, feces on their own. Observable indicators of fecal incontinence include difficulty, discomfort moving the bowels, hard bowel motion and irregular habit, impaction and leakage, urinary frequency and retention, abdominal discomfort and bloating, diarrhea and frequent need to use the toilet, sudden urges to use the toilet and an inability to get there in time. 6. Skin rash or reddening due to extended contact with feces, involuntary passing of gas, liquid or stools, loss of appetite, lethargy and discomfort related to constipation or diarrhea, soiled underwear or continence products. Factors affecting incontinence. The factors that affect a person's ability to remain continent rely on 2 things. 1. The normal physiological functioning of the bladder and bowel. 2. The absence of any cognitive, physical, medical and environmental factors that act as barriers. The factors affecting a person's ability to remain continent may include, but are not limited to, factors: age, cause children up to 2 years of age lack the brain and spinal cord development to be continent. Older adults may be affected by cognitive function and/or memory due to dementia, confusion and inability to identify and/or locate and/or use toilet properly, an inability to remove clothing in time, or at all unable to wipe themselves and replace clothing, or frailty. Environmental placement of furniture causing obstruction to toilet, impaired mental function, impaired mobility, infections, medical conditions or diseases, walking aids out of reach, cluttered rooms, poor toilet signage, poor lighting, or a cold toilet. Severe loss of cognitive ability, vision, hearing and speech loss, or poor spatial awareness. Use of a wheelchair, walking frames, being overweight, inability to stand or sit on a toilet, inability to wipe themselves or wash hands, inability to remove or replace clothing, or inability to get to the toilet in time. Stomach, bowel and urinary tract infections. Dementia, diabetes, arthritis, stroke, multiple sclerosis, enlarged prostate cancer, Parkinson's disease, bladder cancer, bowel cancer, or motor neuron disease. 10. Weakening of bladder, bowel, pelvic floor muscles due to childbirth, or nerve or muscle damage due to surgery or injury. Medication, neurological disorders, overweight, use of diuretics, alpha blockers, strong antibiotics, or overuse of laxatives. Dementia, Parkinson's disease, motor neuron disease, CVA, stroke, spinal cord injury, or brain injury. Inability to move easily or quickly. 11. Document No. 7-day bowel chart. Please complete details for each time the realdent has a bowel movement. Type of bowel movement. Refer Bristol stool Dolo shit time be continent form scale of stool yes no number of ped clothing changes identify pads or clothing or both lid. Comments, associated circumstances, effects on daily activables, laxative might night 7-3 number 7 am, 4 no T3 nh slept in 7303 4 no nil 8 am 2 to 3 no I stated. Had to push 8 night Dan Plin night 2 n31 n. Hard to go. The Bristol stool form scale. Use this as a guide to the stool type. Type 1 separate hard fumps like nuts, hard to pass. Tura 2 sausage shaped but lumpy. Type 3 like a sausage but with cracks on its surface. Tura 4 like a sausage or snake, smooth and soft. DJJ versus Bojo Od Fub. Tura 6 saft blobe with clear cut edges passed quickly. Type 6 fluffy pieces with ragged edges, a mushy stool. Type 7 watery, no solid places, entirely liquid. Soapit Street Joskonje Pobo 87110 Profe 13. Interventions, products and practices for incontinence. It's important to choose a continence product that meets the individual needs, circumstances and preferences of a person. Andrea Lord, continence specialist, educator and advisor. Common interventions: investigate and treat underlying conditions because incontinence is a symptom of an underlying problem. Identifying what conditions may be contributing to the person's problem is vital. A thorough health assessment should be conducted by a general practitioner as part of the continence assessment. Common conditions and disorders that may contribute to incontinence include obesity, diabetes, arthritis, pain or delirium. Urinary incontinence can be a symptom of a variety of reversible conditions. It is important therefore to identify and treat the reversible causes of incontinence so the issue may resolve or improve. The DIAPPERS mnemonic, a method of making items easier to remember, covers some of these conditions. D. Delirium. I. Infection. A- atrophic vaginitis, urethra in women, inflammation of the vagina, urethra. P. Psychological depression, anxiety. P. Pharmacological medications, E. Excess fluid intake or output. R. Restricted mobility, restricted environmental conditions. S. Stool impaction. Common interventions. There are no limits to the number and type of interventions that can be put in place for people living with incontinence. Even the simplest changes can make a difference. 14. General fitness. Encouraging the client to maintain and/or regain overall fitness will also contribute to regaining continence. Improvement in mobility enables a client to more easily transfer from bed to chair or walk to the toilet. For example, toileting issues may be helped by Black Circle, an individualized toileting program developed after an individual continence assessment and summarized on a continence care summary. The use of toileting aids, a commode in a person's bedroom, giving them help with their mobility and assistance in removing clothing, wiping and dressing, or providing night lights, providing sufficient time for a person to complete their toileting needs and ensuring they are sitting in the right position to go to the toilet, providing a comfortable, warm toilet environment, not too cold or too hot, no drafts, dim lighting or glaring lighting. Environmental supports may also be given through the use of signage, ideally pictures, to indicate the location of toilet and bathroom facilities, removing clutter or floor rugs to enable a clear path and easy access to toilet and bathroom facilities, toilet hand grip rails near the toilet to support sitting down and getting up, non-slip mats on the toilet and bathroom floor, providing a comfortable warm toilet environment, not too cold or too hot, no drafts, dim lighting or glaring lighting, placement of people with bladder and or bowel problems close to toilet, for example, not in the dayroom, in a chair furthest away from the toilet, ensuring walking frames are within a person's reach, ensuring the person can get in and out of chairs with ease, placing a commode and or urinal within easy reach of the person. 15. Clothing modifications may support people with mobility issues to toilet with ease through trousers with elasticized waists that are easy to pull up and take down, Velcro fastenings instead of buttons, and zips, tracksuits, which are easier to put on and take off than other clothing. Use of medications. A number of medications can be given by general practitioners to help incontinence by treating bladder storage and bladder voiding issues. People taking medication should have a regular medication review to identify any side effects that may contribute to urinary or bowel problems. Information, education and resources on incontinence can also be given to the person and their family or whānau. This can support their understanding of the issue and the interventions that can be used to manage it effectively. Lifestyle interventions for management and treatment of incontinence. A one approach fits all stance can't be applied to the treatment and management of incontinence. Every person is different, for example, their lifestyle, the degree and severity of their incontinence, their general health, their medical issues, and every person has different needs. Common lifestyle interventions: modification of daily food and liquid intake. The person and the support worker may identify the amount of fluid intake required to meet the client's daily needs to maintain a healthy bladder-filled circle function. Identify types of fluids consumed that may act as an irritant, such as coffee, tea, carbonated drinks, or alcohol. Review the timing of fluid intake. For example, have the last drink 2 hours before bedtime. For people experiencing problems with noctury, think about the success of the treatment and or management of incontinence depends upon the type of incontinence experienced and the interventions chosen to manage it. 16. Record the person's intake of foods that contain adequate levels of fiber to ensure the nutritional guidelines for 30 grams of fiber per day is met. Modify fiber intake as required. For example, reduce or increase fiber intake, or if a person is eating a kiwi fruit a day to help maintain a regular bowel habit, ensure this can continue. Maintenance of regular bowel habits. The aim of this is to help the person maintain healthy bowel elimination and avoid constipation. This requires the support worker to identify the person's regular bowel habit using the 7-day bowel diary report and record any changes from the person's regular bowel habit. Provide an ideal environment for regular bowel habit, such as the use of a footstool for people who haven't had a hip replacement, ensuring the person's safety and preventing falls. Enable the person to get to toilet at the time they are most likely to empty their bowels, for example 15 minutes after a main meal or first thing in the morning. Prescribed medication to help regulate the bowel habit and motions, for example, laxatives or constipatory agents. Regular pelvic floor muscle training exercises known as pelvic floor or Kegel exercises. These specific exercises are designed to help control urine leakage by improving the strength and function of the urethral sphincter and regain bladder and bowel control. They are useful in the treatment of stress incontinence, overactive bladder, and fecal incontinence. Retraining the bladder. This is a treatment for people experiencing symptoms of overactive bladder. The aim is to increase the amount of time between toilet visits, increase the volume of urine passed at each visit, and increase bladder control. This is achieved through use of a bladder diary, a frequency volume chart noting time and volume output, deferment techniques, distractions, pelvic floor muscle exercises, relaxation techniques, and stress management techniques. Incontinence and Interventions US 28546 Learning Guide O Career Force, Issue 2.0 June 2019 1717. 1717. Weight loss and/or the treatment of any underlying conditions increasing general fitness and avoiding constipation. The addition of medication. Develop an individualized toileting program. An individualized program is documented after an individual continence assessment is completed and the findings listed on a continence care summary. The person is encouraged to follow the program with the support of their support worker. This may include the use of toileting aids, a commode in a person's bedroom, helping clients with their mobility and giving assistance to remove clothing, wipe and dress, or providing night lights, providing sufficient time for the person to complete their toileting needs, ensuring they are sitting in the right position to go to the toilet. Use of medications. Medications can be prescribed by general practitioners to help incontinence by treating bladder storage and bladder voiding issues. People on medications should have a regular medication review to identify any side effects which may contribute to urinary or bowel problems. The use, care, removal and disposal of continence products. The NZ Continence Association says the ideal continence product measures an A to F on the alphabet. Yes, truly, the ideal product should A. Always work. B. Be easy to use or manage. C. Comfortable to wear and protect skin. D. Disguise or contain odor. E. Easily concealed under clothing. F. Finally, easy to dispose of or wash and at a reasonable cost and availability. 18. A number of other factors that will influence the use of continence products include the type of incontinence experienced. For example, are products needed for daytime or nighttime use? The preference of the person and their support worker. This may be influenced by the choice of clothing and lifestyle options. The person's physical characteristics, their mobility, vision, hearing, weight. Their person's health, for example, they may have infections or other health issues and conditions. The state of the person's mental function, the effectiveness and availability of the product itself. Storage and cost factors. Appropriate products are many and varied. Absorbent or containment aids can be either disposable or reusable. Disposable pads include mesh briefs with pads or liners, slip-on pull-up pants, all-in-one briefs. Some pads have an adhesive strip backing and require firm-fitting underwear. These products are designed for small to large volume urine loss and may have wetness indicators which help indicate when the product needs to be changed. Reusable pads include pockets, pants with an integral pad, washable gusset, or all-in-one briefs and liners. There are also bed pads and chair pads to protect beds and chairs. Bed pads provide additional backup for products worn on the body. Common collection aids. Common collection aids include a commode, a chair with a waste collection bowl under the seat. Absorbable granules or sachets which can be placed in urinals and commodes to absorb urine and minimize problems with accidental spills. Urinals, a handheld urinal for both men and women. There's a special attachment for women. Male handheld urinal, female attachment. 19. Bedpan, a portable container, either reusable or disposable, used on the bed. Urodomes and drainage bags for men. Urodomes are external disposable self-adhesive latex or plastic sheets fitted over the penis to collect and drain urine into a drainage bag. They may also be referred to as external catheters. Source: Hollister ANZ. Urine flows down urinary catheters and drainage systems. A catheter is a hollow tube inserted into the bladder via the bladder for the purpose of draining urine or instilling fluid as part of a treatment. Internal catheters can be used in one of three ways. Through catheter to empty the bladder of urine. Bladder Adam 1. Intermittent. A catheter is passed into the bladder via the urethra to drain the urine. It is removed once the bladder has drained or medication has been effective. 2. Urethral indwelling catheter. A catheter is passed into the bladder via the urethra to drain the urine and remains in place. The duration of catheterization may be short-term or long-term. 3. Suprapubic indwelling catheter. The catheter is passed into the bladder via the abdominal wall. A suprapubic catheter may be chosen for people who are wheelchair-bound and sexually active, or unable to tolerate urethral catheters. Closed drainage systems. Indwelling catheters are connected to a closed drainage system, which includes a leg bag and/or a night bag. Once the catheter is connected to a leg bag, the connection shouldn't be broken until the bag needs changing. A larger capacity night bag may be attached to the leg bag for nighttime use. The closed drainage system is a vital part of the infection control procedures. Another option for clients using an indwelling catheter may be a catheter valve. A valve can be used on its own, or a larger capacity night bag may be attached to the valve for nighttime use. Ostomy pouches. An ostomy is an opening created on the abdominal wall through the skin surface for discharge of body waste, urine and/or feces. An ostomy is created through surgery to maintain a person's normal urinary and bowel function if they don't have a rectum or have a 20 diseased colon or bladder. 20. A colostomy is an artificial opening in the colon, large intestine, which is brought to the surface of the abdomen. An ileostomy is where part of the ileum, small intestine, is brought to the surface of the abdomen. This is usually done when the colon is diseased. A urostomy is where urine is diverted from the urinary tract to the surface of the abdomen. Colonostomy bag source. http://www.webmd.com. Ostomy pouches come in one-piece systems, where the ostomy pouch and skin barrier protection are joined together permanently, and two-piece systems where the ostomy pouch and the skin barrier protection are separate. In one-piece systems, the skin barrier and pouch or bag are bonded together and applied as a single unit. In two-piece systems, the skin barrier and pouch or bag are clipped together and may be applied in two steps. Firstly, the skin barrier wafer, and then the pouch is clipped into position. Skin care. People using continence products should have their skin checked regularly, as skin in contact with urine or feces leads to skin breakdown. Skin that has had contact with urine or feces should be gently washed with soap and water. Specialized cleansers and skin moisturizers that provide skin barrier and protection should be used for people with vulnerable skin. Skin care products should be applied sparingly and according to manufacturer's instructions. For example, a thick application of barrier cream may affect the absorbency of continence products. Every continence product and collection aid available has their own specific instructions about application, care of the product and product removal. Support workers need to be familiar with the products, their specific characteristics, application and care, and various benefits and limitations, their shelf life, their working life and appropriate disposal methods. 2121. Infection control practices. Support workers must adopt and consistently use basic infection control practices. Organizations will have their own specific, documented policies and procedures in this area. The following points generally apply. Always wash your hands before and after any and every contact with a person you support. Deal with incontinence events promptly. Do not allow the person to be unattended for any length of time. Do not place urinary drainage bags directly onto the floor. When handling catheter bags, changing bags or emptying bags, avoid touching the connections at the end of the catheter and drainage bag. Empty catheter bags carefully into a toilet or designated container. Hold the container at an angle to avoid splashes and bubble formation. Ensure catheter outlets are clean and dried after emptying. Always check catheter bags for leakage and replace them if they're worn or damaged. When changing continence products such as pads, remove them from the person's back, that is away from the urethral opening. Ensure soiled items are removed immediately and either promptly disposed of, cleaned and/or sterilized. Always ensure that urinary drainage bags are placed lower than the client's bladder. Think about, did you know that 42.5% of all people with incontinence suffer from skin problems? JUNKINANDSELEKOF 2007, as cited by NZ Continence Association. 22. For people experiencing incontinence, skin care management is very important for maintaining skin integrity. Good hygiene is essential to prevent odor, maintain a healthy skin environment, and avoid infection. Source: 3M Medical. Aging skin is generally more vulnerable and needs continual care and assessment in relation to incontinence. As people age, the skin becomes thinner and its ability to act as a barrier to the external environment is reduced. It also contains less collagen and is often dry, which creates cracks where bacteria may multiply. Because aging skin is more prone to damage, good skin care management for a person with bladder or bowel problems is essential. Urine and feces can cause damage to the skin, causing redness, irritation, and soreness. The skin areas most at risk are the perineum, the general region between the anus and the genital organs, the inner thighs, and between the buttocks. It is important to make sure that the person's skin is both clean and dry. When changing continence products, it is also very important to regularly check to make sure that the person is not suffering from any skin breakdown as a result of their incontinence. 223.23. References: Continence Foundation of Australia, N.D. Pelvic Floor Muscle Training for Men. 05. Brochure, Australia. Continence Foundation of Australia, N.D. Pelvic Floor Muscle Training for Women. 06. Brochure, Australia. NZ Continence Association. N.D. Continence Care Training Program, PowerPoint Presentation, New Zealand. Deakin University, N.D. Continence, Deakin University, N.D. 3-day document. Deakin University. Document Australia. Deakin University. N.D. Continence Screening Form. Australia. Deakin University. N.D. Australia. N.D. Monthly Bowel Chart. Document Peacehaven 2006 Bowel Facts retrieved June 2011 from Australia. http://www.12learn.blogspot.com/200 Rushed. Human Bladder. Shaw. D. 1424.